Namaskar and good evening, everyone. A very warm welcome for the webinar on GI updates. And with immense pleasure, I would like to invite the program convener, Dr. Vijay Kumar, who is Senior Consultant Medical Oncology at Sakara World Hospital, Bangalore, for the welcome and introductory note and to take the proceeding forward. Over to you, sir.
Thank you, madam. Am I audible?
Yes, sir.
Perfect. Thank you. Good evening to one and all. Firstly, at the outset, I'd like to thank Horizon for the hospitality and also our sponsors for this meet. So this is the first GI update. So primarily, we're going to deep dive into what is happening in esophageal cancers, and then a little bit on the modern landscape in hepatocellular carcinoma. We're going to have a heated panel discussion on what are the nuances in management of hepatocellular carcinoma in the metastatic stage, and how are we going to deal with them in our routine practice. Subsequently, we're going to have a little bit of talks on what the supportive care space where chemo-induced nausea vomiting, what are you going to do in this patients and how are we going to handle. And then we have another session on a very important topic called anemia in cancer, which is a massive space which is very important for our patients, followed by some key insights on how skin manifestations in cancer are of top priority. So at the outset, I would also like to thank Roche and Glenmark and Dr. Reddy's for this opportunity. So without further ado, I think we can get going with the first topic of today. So I would like to invite Dr. Srikanth. So can I have the next slide, please? So this session is primarily sponsored by Glenmark. Can I have Dr. Srikanth's topic, please?
Sure, sir. Shall I share my slides, sir? Is that fine?
Sure, Srikanth. You're good to start. The stage is yours.
Thank you so much, sir. At the outset, I would like to thank Horizon, all the academic partners, and all the consultants for giving me this opportunity for today to present the new kid on the block, that is tislelizumab. So first, I'll be sharing my screen. Is my screen visible to all?
Yes, Dr. Srikanth, it's visible. Yes.
Thank you, sir. Yeah. So the topic for today is the new kid on the block, that is tislelizumab, and its role in the management of esophageal carcinoma. I will just briefly brief all of you about the PD-1 and the PD-L1 inhibitor landscape that is currently available in the world and in India today, the tislelizumab profile, drug profile, and its clinical evidence landscape from the various rational trials, after which I will be concluding. So there have been many approved PD-1 and PD-L1 antibodies that have been in use since 2014, with nivolumab being the first. Right now, we have around 11 molecules which are either PD-1 or PD-L1 inhibitors. The new ones on the blocks are tislelizumab. Along with that, we have cemiplimab, sintilimab, and camrelizumab, and last but not the least, serplulimab. So coming to the drug profile, tislelizumab is a humanized IgG4 monoclonal antibody with high affinity and binding specificity for PD-1. So it blocks the PD-L1 and the PD-L2 to PD-1 receptor. Is differentiated by its unique binding epitopes, kinetics, and orientation, which I'll be talking in the subsequent slides. The recommended dosage, as we all know, is around 200 milligram every 3 weekly. And there have been greater than 20 potentially registration-enabling clinical trials in many countries all over the world, with enrolling around 13,000 patients, with more than 750,000 patients being treated commercially for the cancers. So it has a good broad global clinical development program with around 12 approved indications, with 5 being under review, 21 registration trials, of which 11 are global. It is primarily a Chinese molecule, so nasopharyngeal cancers and lung cancers, that is non-squamous as well as squamous, and then we have the esophageal and hepatocellular cancers and urothelial cancers, and other basket trials that involved all the MSI high or DMMR solid tumors and Hodgkin's lymphoma. So coming to its structure, it has a distinctive binding orientation to PD-1 that encompasses the binding orientation is slightly different from that of pembro and nivolumab. So this orientation gives a largely overlapping cover of the PDL1, leading to the complete blockade of PD-1 PDL1 interaction. That interaction being more than 99%. Compare that to pembrolizumab or nivolumab, where the interaction is just 80 to 81%. So we all know that the T cells express the PD-1 and the tumor cells express the PDL1, and the interaction of both can lead to immune exhaustion. And blocking this will actively activate the immune system, which will help us fight against the cancer. Also, what is important is when anti-PD-1 antibodies bind to Fc receptors present on the macrophages, these Fc gamma receptor positive macrophages attack and consume the PD-1 positive T cells, resulting in a diminished anti-tumor response. So what this tislelizumab does is it spares this Fc gamma receptor binding, and it allows the PD-1 receptor to be available for the interaction and blocking. So that's how it is different in structure and its mechanism of action. Also, coming to the pharmacokinetics, in preclinical models, tislelizumab demonstrated high target affinity and slow dissociation. It is around 50 to 100 times slower compared to other molecules, that is pembrolizumab or nivolumab. Also, in the preclinical models, tislelizumab has a lower half maximal inhibitory concentration value, thus having stronger anti-tumor activity, with the IC50 values of pembrolizumab and nivolumab being 1.3 to 3.5 times lesser than that of tislelizumab. Coming to the clinical evidence, now that we have gone through the structural differences and pharmacokinetics, let's go through some trials. There have been many clinical trials conducted with tislelizumab across various indications that we briefly went through in the previous slides. And they have been approved in various unions such as the European Union, US FDA, Canada, Australia, China, and even in India, DCC approvals have been given for in the lung settings as well as in the esophageal settings. We have the rational 303, 304, 307 in non-small cell lung cancer settings. The esophageal squamous cell carcinoma, I'll be shortly talking in the subsequent slides, along with gastric cancer. We also have approved indications in urothelial cancers, Hodgkin's lymphoma, hepatocellular carcinoma, where it has been compared with sorafenib, and basket trials that included MSI high or DMMR solid tumors. Last but not the least, nasopharyngeal carcinomas. Not only those trials which have been completed, but we have other ongoing clinical trials with tislelizumab, which include novel combinations, including novel bispecific antibodies such as zanidatamab, which just goes on to show the versatility of this tislelizumab molecule and its various combinations and that can be explored in clinical practice as well as in clinical trials. So coming to the esophageal cancer burden, coming to the epidemiology, it is one of the top 5 most frequent cancers in males, with it being the third most common in prevalence. And when both the genders are put together, it comes to the 5th position. And not only is it incidence is pretty high in India, but its mortality and incidence in the males are around 2.5 times higher than that of females. And 85% are of squamous histology, and most of them are diagnosed at a metastatic stage of around 38%. Even when diagnosed at an early stage, the 5-year survival rate is pretty dismal at 20%, which falls to even dismal rates that is 6% with advanced stage disease. We all know that the upper 1/3 and 2/3 and have the squamous cell cancers, which is the most prevalent cancer, that is around 85% worldwide. It commonly occurs in the younger patients and it has a very poor prognosis. When it comes to adeno, it predominantly occurs in the gastroesophageal junction or in the lower third of the esophagus. It occurs in older patients who are obese, who have a history of reflux, and they also have a considerably poor prognosis. So coming to some clinical trial data, that is Rational 306, which compared tislelizumab with chemotherapy versus placebo with chemotherapy for advanced or metastatic esophageal squamous cell cancers in the first line. Rational 306 was truly a global trial which included around 649 patients from around 162 sites, with 75% being from Asia. The rest of the world was around 25%. So this global randomized double-blind parallel placebo-controlled phase 3 trial, what it did was it included patients of unresectable locally advanced metastatic esophageal squamous cell cancers with no prior therapies with ECOG PS of 0 or 1 and randomized them to tislelizumab plus chemotherapy or placebo with chemotherapy. The chemotherapy being either a fluoropyrimidine plus platinum or a paclitaxel plus platinum. The baseline PD-L1 status was categorized into a tumor-associated positivity of greater than or equal to 10% and less than 10%. The primary endpoint being overall survival, secondary endpoints being progression-free survival, objective response rates, and duration of response, and so on and so forth. So coming to the overall survival, we can see a clear separation of the two curves that shows the benefit of tislelizumab over the placebo arm, with the median OS being 17.2 months versus 10.6 months, with a hazard ratio of 0.66. That is around 34% reduction in the risk of death, which with a p-value that is really significant. So this is around 6.6 months of additional OS in the first line setting. Not only was the OS prolonged, but also was the median PFS was increased by around 2 months from 5.6 months to 7.3 months, with the sustained separation of the curves that continue to remain separated over time, with hazard ratio of 0.62. The objective response rates were also pretty good, 63.5% versus 42.4% versus placebo. It was also sustained over a period of time at 7.1 months versus 5.7 months. Coming to the safety and tolerability, we have all used tislelizumab in the real world setting as well. And not many side effects were seen in these trials. And both of arms had really comparable side effects, predominantly due to the chemotherapy arm. So now that we have seen the data in the first line setting, the Rational 302 was earlier done, and it was done in the second line setting of esophageal squamous cell cancer, which compared tislelizumab against chemotherapy. So the study design in this area was any advanced metastatic esophageal squamous cell carcinoma which had progressed after a first line treatment, the ECOG PS of 0 or 1. And in one arm, we had tislelizumab given 200 milligram every 3 weekly, and in the other arm, we had any one of the three chemotherapy molecules, that is paclitaxel given 3 weekly or weekly, docetaxel given 3 weekly, irinotecan given 3 weekly again, and all treatment was continued until progression or further toxicity. Baseline PD-L1 status was categorized again with a TAP score of greater than or equal to 10% and less than 10%. Primary endpoint was again nice to see that it was overall survival, and other secondary endpoints being PFS, ORR, duration of response, and so on and so forth. Again, in the second setting, we had a really good separation of the curves, both in the overall patients as well as in the sub category of patients who had greater than or equal to 10%. In the overall patients, it resulted in an additional OS of around 2.3 months with a hazard ratio of 0.7. When the TAP score was greater than or equal to 10%, it was even better with the 3.5 months additional OS with a 46% reduction in the risk of death. And also, the PFS benefit was also seen. It was clearly the Kaplan-Meier curves are separated and continue to stay separated. And it started separating after a period of around 3 months. So this late but sustained separation of curves is what we generally see with all the immunotherapy molecules. And it was also associated with a greater objective response rate of 52%, sorry, 20.3% versus 10% compared to chemotherapy. And the duration of response was also around 7.1 months versus 4 months. Again, it was generally a really tolerable safety profile compared with chemotherapy arm, with lower rates of grade 3 treatment emergent adverse events and treatment related adverse events, and lower rates of treatment discontinuation. So now that we have seen the data in the first and second line setting of esophageal cancers, let's go through some indirect comparative data. So on the left hand side, we have two veterans, that is pembrolizumab and nivolumab, and the two new kids on the block, that is toripalimab and tislelizumab. On the right hand side, we have those molecules which are not available in India, barring serplulimab. We can clearly see from this slide that the new kids on the block, that is toripalimab and tislelizumab, really score better over the older immunotherapy molecules. You can clearly see the difference in the median overall survival of around 17 months seen with these two new molecules compared to the older ones, that is around 12.6 to 13.2 months. So When it came to the second line setting, again, the results were comparable with pembrolizumab and nivolumab, with the median OS of around 8.6 months versus 8.2 and 10.9 months. The median PFS is also comparable. So now that we have completed seeing indirect comparative data on the esophageal cancer settings, let us move on to the gastric cancer with a short overview on disease background. Coming to the epidemiology, it is the fifth most common cancer in India in males, and it has predominantly two major histological subtypes. That is intestinal with which is well differentiated and has a better survival outlook than diffuse adenocarcinomas, which have traditionally been resulting in poorer prognosis. When it comes to gastric cancer, it can mean either adenocarcinoma, stromal tumors, neuroendocrine tumors, or lymphomas. And adenocarcinoma accounts for around 90 to 95% of the gastric cancer cases. Ration 305 was done in the first line setting, tislelizumab plus chemotherapy versus placebo with chemotherapy for advanced or metastatic gastric or gastroesophageal junction cancers, adenocarcinoma. So this was again a randomized double-blind placebo-controlled phase 3 study, which had this histologically confirmed gastric or gastroesophageal junction tumors. Very important to note that it included only patients with HER2 negative disease with a PS of less than or equal to 1, who had measurable disease and who had never received any form of therapy before. They were randomized to tislelizumab 200 milligram given every 3 weekly, plus capox or 5-fluoropyrimidine, that is 5-FU, along with cisplatin, and a placebo arm in a 1:1 ratio. The primary endpoint was again overall survival in PDL1 positive patients. Here, the PDL1 cutoff was around 5%, which is what the NCCN guidelines also follow. And the key secondary endpoints were PFS, ORR, and DOR, and disease control rate, and clinical benefit rate, and so on and so forth. The baseline characteristics were well matched between the two arms, with the median age being around 60 years of age, predominantly Asian population of around 75%, with predominantly good ECOG PS, mostly stomach population, PDL1 and PD less than and more than 5%, almost being equal, 45% versus 54%. Predominantly, they received capox. I think it was because of the ease of 3 weekly. So this is a 3-year follow-up data of Kaplan-Meier curves showing on the left-hand side all patients, and on the right-hand side with a TAP score of greater than or equal to 5%. We can clearly see a clear separation of the Kaplan-Meier curves, and no point are they crossing over sustained separation. And it is around 15 months versus 12.9 months with the HR of 0.79. Even better when the score was greater than or equal to 5%, 16.4 versus 12.8 months, with an even better hazard ratio of 0.71. PFS again was slightly better, 6.9 months is 6.2 months. And the tumor response was also significantly better, of around 47% versus 40%. Again, when it came to the safety, the adverse events were almost similar in both the arms, with predominantly the adverse events being a result of chemotherapy rather than the immunotherapy arm. So this is another indirect comparison data that in the first line setting of gastric cancer and gastroesophageal junction cancer tumors. Clearly, you can see the median OS that is numerically better with the rational trial 16.4 months versus 15.7 and 14.4 months respectively with pembrolizumab and nivolumab. The median PFS was again 6.9 months, almost on par with other immunotherapy molecules. So coming to the guideline recommendations. So what the NCCN guidelines recommend is that it is a category 1 preferred regimen when it comes to esophageal cancers in the first line setting when the PDL1 CPS is greater than or equal to 5, and they should be HER2 negative. And also it was when it came to the gastric cancer settings, again it is a category 1 preferred indication in combination with capox or FOLFOX for PDL1 CPS greater than or equal to 5 in again HER2 negative patients. Other indications for the same include hepatocellular carcinoma, regarding which we'll be having a detailed subsequent panel discussion, colon cancers, that is dMMR and MSI high, classical Hodgkin's lymphoma, and esophageal carcinomas. So the pivotal clinical trial summary that we have discussed for today were the rational trials in the first line settings, second line settings, and in the first line gastric cancer or gastroesophageal junction tumor settings. which clearly showed the benefit of tislelizumab with respect to overall survival, PFS, response rates, and the adverse event profile. That concludes the presentation from my side for today. Thank you all.
Thank you, sir, for the excellent talk. Now, I would like to welcome Dr. Vijay, sir, for the panel discussion. It's a sponsored session by Roche. And for the panelist, I would like to invite Dr. Pratyusha Iga. She is Consultant Medical Oncology, Krishna Institute of Medical Science, Bengaluru. Dr. Vijit Shetty, Professor Medical Oncology, Shima, Bangalore. Dr. Hemant Kumar, Consultant Medical Oncology, Management, Bangalore, Institute of Oncology, Bangalore. And Dr. Prahlad Ilimati, Consultant Medical Oncology, Mazumdar Shaw Medical Center, Narayana Health City, Bangalore. Over to you, Vijay, sir.
Thank you. Thank you so much. Firstly, at the outset, I'd like to thank Roche for giving me this opportunity. And I hope my panelists are there. Let me just... Can I share the screen or is it possible for you guys to handle the screen at the back end?
Sure, sir, sure.
Sure, perfect. So are my panelists here?
Yes, sir. You're here.
Yeah, hi. Hi, Dr. Pratyusha. I
Hi.
hope Prahlad is there.
Hemant here.
Hi, Amit. How are you?
Oh, fantastic.
And I hope Prahlad is also around, correct? Vijit is joined?
Yeah, hi, Dr. Vijay. Hi.
Hi, Vijit.
Sir, I just now spoke to Prahlad, sir. I think he has not joined yet.
All right, perfect. I think we'll start off and we can let Prahlad join in slowly with time. Sure. So, firstly, thank you, Roche, for this opportunity. Probably let's get going with Dr. Pratyusha. So, Pratyusha, I think metastatic HCCs, right now, what we do in clinics is pretty much typically immunotherapy based. Are you still using, say, other TKIs as a monotherapy in these patients? Probably I would like to start from Pratyusha. You can
No,
take
sir.
that.
Yeah, we have completely shifted to IO VEGF or IO combination a long time back.
Okay.
Listen, until it's a contraindication to use immunotherapy, I would not look at any TKI.
Perfect. So the Mangalore Medical Oncologist also agree to that, or is your preference still TKIs for some reason?
No, I think again we have switched to IO-based combination wherever feasible, either logistic or if any contraindication, then probably we might use TKI.
Perfect. Vijit, I think it's probably the same. So Vijit, I think now that we have different combinations available in clinics, so is there a go-to between the three first-line regimes? How do you choose these? Probably I'd like to hear your thoughts on that, Vijit.
Yeah, so I think we all have switched to IO-based treatment upfront. I hope I'm audible, Dr. Vijay.
Yes, please. Thank you.
So I think we have shifted to IO-based practice. To choose between, say, Atezobev and say Durvalumab, Tremelimab combination STRIDE, I think the variceal status is the only kind of the thing which we look at. If someone has a large esophageal varice, then I think that's where you would probably think about not using Bev. But again, if somebody has undergone upfront banding, then probably that kind of negates it. But if someone has a large esophageal varice and someone has a hypertension, probably there again we'll tend to think about Durval Trem. So other than that, I think Atezobev is probably the go-to combination. And again, I think NCCN category 1 tislelizumab also has come, I think, now as a category 1 recommended. So we have a lot of players in that space. But I think from 2019 onwards, since we made the shift to IO with Atezobev, I think we are very comfortable using Atezobev combination, unless there is some major contraindication for the use.
Perfect. Now that you actually bought in that component of doing a monotherapy with, say, Tislely, I'd like to ask Pratyusha. Pratyusha, have you ever used monotherapy Tisli in first line for HCC, although that's an NCCN approved regime?
No, sir. I have not used Tiscali in HCC at all. I've used it
Anybody in the
other
panel has used it?
No, I have not used Tiscali. In the past, I have used Nivolumab, single
Okay.
agent. Most of the time it is in second line, but I have used upfront when probably I felt lenvatinib was not a good choice. Atezolizumab was difficult due to presenting varices. I've used Nivolumab. Not a great response though, but not Tiscali though.
Perfect. Perfect. So the previous slide, please. Could you just go back to one slide in the back? Could you just go back by one slide, please? Another slide, another one. So I think we were just looking at a lot of other parameters before we started or before we decide a particular treatment option. So even between the three to choose with, so for example, let's start off with patient with bleeding. So say patient has a high risk of bleeding. So what are your list of, say, priorities or your checklist before you go into Atezolizumab?
Yeah. So if somebody has got a potential high risk of bleeding, I would definitely do a endoscopy, ensure that if any varices are there, ligation is done. Ask for history of bleeding. Many of the CLD patients do have pre-existing thrombocytopenia that again probably puts them at high risk. Uncontrolled hypertension is also something that I would probably thought about. I've had recently two patients who have had massive GI bleed in the past. They've got varices banding done, but are still probably not too comfortable in proceeding with the Atezolizumab, knowing that you have alternate treatment option that is available. So I think these are the ones that probably I look at and then go about, and definitely past history of any other autoimmune issues. That is something that I've learned the hard way. Sometimes not asked adequate history and ended up being in trouble. I've got now one his patient whom I had started lenvatinib post TACE. I was discussing immunotherapy because patient was not tolerating lenvatinib, very bad mucositis. Then meanwhile developed skin lesions, and then I asked again history. Then it is long back I had history of psoriasis. So complicates things. So it is very important that we do ask history of autoimmune issues. Sometimes only when we landed in trouble we know that we have missed it.
True, no, very clearly highlighted. I think especially psoriasis is something because it's not something which is very significant and people are on medications and they always deny it, or it's probably unidentified and it flares up. Very clearly brought about that point. So what are the other so do you routinely, probably I'd like to ask Pratyusha here, Pratyusha, do you routinely work up for autoimmune disease prior to start of immunotherapy, or what is it in your clinics which you're doing routinely?
No, so we don't only work up, only we just take a thorough history as to whether the patient has any autoimmune disease or not. Like Dr. Hemant has just put forth here, not in HCC, but even I burnt my hands in a case of breast cancer TNBC where a patient had psoriasis, never told about it. Then we gave Pembro and then it played up and all of that. But yes, history is the only thing that we do. But we don't actively work up. But if we are starting an IO, then we will baseline investigations like TSH, cortisol, all those things we will do just to document.
Perfect.
Yeah.
Perfect. Perfect. So, Dr. Vijit, now that you have Stride versus, say, the Checkmate 90W, one dose of priming with CTLA4 versus 4 doses of CTLA4. So, what's your take on what's, say, for example, you don't want to use BEV for some particular reason, say, patient has bad varices, or say, child B, and because the data for Atezolizumab was, say, IMPAR 150 was primarily for child A, but although we do use this up to child B score 7 is still something what we routinely use. But say for some reason you're not able to use Atezolizumab and you want to err towards one among the two IO combinations, what's your preference between the two?
So again, Stride I have tried in not much experience, but couple of patients. I didn't really get that great a response with that. So again, not much of an experience. I would like to say that. But Nivo EP I have not really tried in HCC. I think it works best in RCC kind of a scenario. I have not really tried it in HCC yet. Mainly because I'm very comfortable using Atezolizumab. So I think I'm very comfortable. But yes, if there is a scenario where there's a contraindication to use bevacizumab, between these two, I would again be quite wary about the autoimmune side effects by using IOIO. The autoimmune hepatitis is something which is really worrisome in patient who has a borderline. Like you said, you are pushing it in a Child-Pugh B7. I think we'll be kind of pushing it a bit. We are very worried about the decompensation of the liver. So there, I would be very wary about using IIO combination. There, I would probably think about de-escalating rather than escalating with the dual IO. But someone who has Child-Pugh A with contraindication for bevacizumab, between the two, I think it's really hard to choose. I think with more experience, I'll be able to tell better, but I haven't really used. But if I may ask you this, have you tried NeoEP in HCC and what has been your experience, Dr. Vijay? If you could enlighten, if you have used it.
Yes, yes, please. So we've actually used Ipi-Nivo in HCC. So only concern for us has always been the toxicities. So because with 4 doses of anti-CTLA-4, you always end up getting a lot more toxicity. So we've had 2 patients where we've given Ipi-Nivo, but the toxicity is slightly more to handle with. Otherwise, especially the doses of EP what you use there is very low. That's very similar to what we use. So we don't actually go by what the standard approval is. We use the RCC mode, 1 mg per kg body weight. You always get away with that 50 mg. And toxicities are low. Thyroid, except for that, mostly sometimes I've had a lot of diarrhea, which is a significant concern. We've had one patient developed colitis. We did have to stop and de-escalate and take off, and these things did happen. But it's actually not bad. But my thought process is more towards the STRIDE regime now, because 1 dose of priming is sufficient for you to get all the other kind of necessity ingredients which is required. And also primarily, if you look at it, tremelimumab actually has more potency, or rather 3 times more binding affinity to CD28 compared to other molecule. So you've somehow kind of understood with time that just 1 dose is sufficient rather than using 3 doses on the whole. And I would like to probably hear Hemant's thought on this. Between the 2 IO-IO combinations, Hemant, you've tried either of it. What's the status?
I've tried both. Unfortunately, both of my patients with Durva Tremblay progressed extremely rapidly. So I did not have one. Basically, in 1 cycle, within 28 days, we lost him, and it was due to disease progression. He had it seemed like probably a bad biology disease that he had, very high AFP, very high PIVKA. And I initially thought it was immune-mediated hepatitis, but then when I repeated AFP PIVKA, it had doubled by 28 days. So that was that. My concern with Durva Tremblay is probably some of these patients who are symptomatic, in case they've got HCC with symptoms. The response rates are better with NeoEP. Though both have kind of nearly equivalent issues with IO-related adverse events, NeoEP gives us probably the time to think about. The other thing that you told of EP of 1 mg per kg, I have started a patient with 3 mg per kg EP and Neo. I am just hoping things go well. So because this patient also is by the book, so I wanted to just go with that. But that is what. So the response rates are better. Always my comfort has been Atozobev. I've got good experience and patients who have done well on Atozobev. I've got one patient who had progressed on Atozobev, went multiple lines, now nearly 5 years. There is some nodal disease, but no major disease. So definitely it gives that OS benefit and long-term experience, ease of handling the drug is something that I've seen. No major autoimmune adverse event that I've seen with Atozobev. And the response rates are pretty good as well.
No, totally agree with you. I think putting this into perspective, now that you brought in the median overall survival. So if we actually look at the 3 studies across, the median overall survival for Atozobev is around 19.3 months, although that was in comparison with sorafenib. And if you look at the STRIDE regime for Himalaya, so it was somewhere around, again, same around 18.3 versus 12.3 for sorafenib. And versus durvalumab, again, that was primarily STRIDE versus single agent versus sorafenib. It was a 3-arm study. Whereas if you look at the Checkmate 9WD, the median overall survival is 24 months, and this was again in comparison with lenvatinib. Now that you have a numerical overall survival, which is the highest with the doublet, is that of a concern? I probably want to ask Pratyusha, is that going to make your decision making more biased and go towards the IOIO combination, or still Atezolbev is here to stay? What's
So
your
that's
take
a
on
very
that?
interesting data, sir, that I read recently that, for any RCT in HCC, this is the highest and the best response that we have ever heard of, Nivo EP, giving almost
Correct.
24 months, right?
Yep.
Yes, it does make nudge towards giving Nivo EP, but of course at risk for a lot of side effects. So I would think twice based upon patient's condition, based upon the patient's child status only is when I will go towards Nivo EP, even though I am still comfortable with Atezolbev. One, because it has been a two-go regimen for almost 4-5 years now. It's like it comes naturally to us. You see a case of HCC and then you suddenly just write off Atezolbev without even thinking twice. But now, yes, because of so many players in the same area, we have to think. So unless and until there are still contraindications to give Bev, I'm not sure if I will still lean towards Nivo EP as of yet. The reason why the numbers are so great right now in this trial is probably because of the selection, the population selection also. They have been very, very stringent about selecting only child pug A and various other factors wherein, they've taken the best of the best HCC patients, probably because that is the reason why the patients have done well. And if you see, even the control arm have done 20 months. Unlike in other trials, wherein they were almost like 11 months or 8 to 10 months, right? So again, that shows like currently, it's all about managing a patient as a whole and not just the managing the disease. So that was done well in the Checkmate trial, wherein they were as a whole managed well in terms of fasciitis or encephalopathy or any other symptoms, right? So I think that is also one of the reasons why they might have fared well. So I would like to critically analyze the trial before I would go ahead with Nivo EP, considering all the side effects that it may come with. But even today, I'm comfortable with Atezolbev.
True, no, I think you brought out a perfect. No, I think you brought out a very critical point there, because the comparator arm across studies were always around 12 months and 13 months OS with sorafenib. But because it was lenvatinib, they had a median OS of close to 18, 19 months. And also the patient criteria, what they used for selection, apparently had more patients with hepatitis B. So actually, there's when I was just preparing the slide set is where I did one where I did look into a literature. Apparently, the real world data from the same Atezolbev group comparing the IMBRAVE 150 versus the real world data says that the median OS is just 12.4 or 13.4. That's because here apparently the Hep B percentages were very high. Patient with hepatitis B was almost close to 50% in IMBRAVE study. But whereas the real world, you always see around 30% of Hep B, 30% of Hep C, and another 40% of combination or non-viral etiologies, which is primarily what we see, which is metabolic syndrome associated. So in these patients is where, again, primarily the benefits seem to have been driven by the Hep B patients, which is received immuno, and thereby you're getting that. But whereas the Atezolbev group had a different combination of Hep B, Hep C, and the non-viral. Despite that, they've had a benefit. So that's one positive feedback on the doublet, or rather the IOIO combination as per Checkmate. So that's something which is really interesting. So now that we've brought in this viral etiology, Hemant, is that of importance to you? How important is, say, etiology in this particular scenario?
Every time I've tried selecting based on the etiology, I've failed. So I don't know. Because you will end up getting enough data for supporting both. Either use IO-based therapy or TKI. There are data to suggest that one over the other, you'll get data. Personally,
True.
things have kind of never gone well whenever I've tried based on the this thing, because I told you about my longest survivor. She is an obese lady with BMI of around 28 or so. So there is data that probably in NASH TKI is probably a better or so, but at Atezolbev she did really well.
True. No, I totally understand, especially when you do a post-mortem analysis of these, it's very difficult. And I don't think there is any study which is powered to answer this question. I think there's only one study called the CARES 310 or 315, which was camrelizumab with rivoceranib and rivoceranib, I believe. So that's apparently had close to 75% of viral etiology patients. Otherwise, predominantly. But again, this study, even IMBRAVE 150 also says in viral etiology, there seems to be a slightly more overall survival benefit seen in the viral population. Vijit, you think etiology is important or it's useless? What's
So
your take on that?
I think there was a lot of interest when initially all this noise came about lenvatinib being superior in a person who has NASH and Hep C and sorafenib. I think that was quite of theoretically very interesting. But I think in the IM Brave they have shown that irrespective of the etiology, atezolizumab works well, and we're kind of sticking to that now. We're not really looking too much into it. At the same time, we are getting our gastrohepatologist involved to take care of the Hep B, Hep C part. But it's not doesn't really matter as far as etiology is concerned. We still go ahead with atezolizumab.
Perfect. Brilliant. Is Prahlad around by any chance? Have we gotten a chance to get Prahlad in? Without any...
Sir, he has not joined it.
He's not yet joined. Perfect.
He has joined now. He's there.
Next slide, please. I think he's joined now. Okay, perfect.
Yes, sir.
So next slide, please. So yeah, this is pretty much again looking at the systemic review and meta-analysis, which says non-viral with atezobev, there seems to be a little better. It's a very there's no study which is ever powered for this, and none of the studies have actually been powered to answer this question. So these are all just post hoc and postmortem analysis, basically, which is just saying, okay, there could be a marginal benefit with one against the other. So the other next problem, or rather the combination, what we always end up is tumor thrombosis, portal vein thrombosis. So I'd probably like to hear Pratyusha's take on, is portal vein thrombosis, when it's present, is that gonna impact your decision making, and how are you gonna kind of take that further, especially in an unresectable situation, unresectable child A setting, Pratyusha?
Sir, so IM Brave has clearly shown that, even portal vein VP4 patients were taken and they did well. So there we have actually proper evidence. The remaining trials have actually excluded those patients. So I think portal vein thrombosis, to go, I will just do atezobev. But otherwise, I don't think I will make any other different decision in such patients.
Perfect. Would anybody have any different thoughts, say, especially with portal vein thrombosis? Have you ever gone in with some form of localized approach, gone in with SBRT to the portal vein and in given systemic therapy in these patients, especially in, say, one single solitary large lesion, more like a Millan's criteria there with a solitary, say, two nodules elsewhere? Hemant, if you've done that kind of...
I was about to ask this question to you, that have you used SBRT for portal vein thrombosis? No, I've still not got the opportunity there. But I do always try and think, because I know that these are the patients who decompensate very rapidly sometimes. So even with one cycle, they are child pug A to B7 or so, and they end up kind of sometimes rapidly deteriorating. So these are the patients where I'm always worried what is going to happen. I was about to ask same if any experience that you have.
True. No, even my experience has been bad. We've given SBRT, but post that they've never really come back because they've decompensated post that. So it's a very bad subgroup, especially if you have a VP3 or 4. 4 is very bad, especially if there's a main portal vein thrombosis. I think it's extremely difficult. It's better to just give systemic and treat the systemic disease burden majority of the times and just hope and pray, because going in for localized treatment in these patients always kind of complicate, which is what we've seen. Prahlad, are you around?
Yeah, I'm around, please.
Hi, Prahlad. So what's your take on, say, tumor thrombosis VP4? Is it atezobev, or would you still say I am trying to consider other IO combinations like the STRIDE or the CheckMate based combinations? Is that an option which you're considering?
No. As Dr. Pratyusha said, I think most of the trials had excluded VP4. I think we have a strong data for atezobev. But SBRT to the tumor thrombus we had given, but I think most of them again develop some decompensation, especially in VP3, VP4. I think we should cautiously select those patients whom to give the SBRT and decide with local original therapy.
Okay. Perfect. So probably I would like to ask anybody this particular question on how long have you been continuing these treatments, because toxicity is a major concern. So what are the common toxicities which you've seen with atezobev combination? Probably, Vijit, you want to take it? Vijit, are you around? Probably is Hemant around? Hemant, you want to take that?
Sorry, I missed the question. I got a call.
No, sorry, no worries. What's the common toxicity what you've kind of had on patients with Atizobev, especially with proteinuria, which is again could be because of the underlying disease, which is cirrhosis causing proteinuria versus drug-induced proteinuria. What's your take on what are the common toxicities you've seen and how do you handle these in
So
practice?
hypothyroidism is something that I kind of routinely check for. I've got patients who have developed. There are some patients who develop initial hyperthyroidism, which you don't have to treat. Wait, because many of the time these end up being hypothyroid later on. Hypophysitis. I had one patient who we were not sure. We thought it was disease progression. He was losing weight and is looking weak, fatigue, but hypophysitis. So we had to involve the endocrinology team and then try to manage it. I've got yeah, I think these are the two common ones that we end up seeing. I've got skin over a year or so, they start having some skin issues, skin dryness, and kind of itching that is seen. But proteinuria, frankly, I've not gone to check much because I don't know if it is due to Atezo or it was due to BEV. Hypertension is something that I try to aggressively manage in case these patients are developing hypertension. Try to manage them with some form of ACE inhibitor and also a combination of beta blocker because again for portal hypertension that works well. So try to do this and then start.
Perfect. Very, very well put in. So, Pratyusha, is your practice also been something very similar? You've had any different toxicities what you've seen in clinics per se?
No, sir. Both Atezolbev and Durva-Tremi I have given. I have not given the rest of the regimens. And both
Okay.
of them, there was only one patient who had, I mean, all of them had actually hypothyroidism, but one patient had some diarrhea just after first cycle. Not sure if it was because of drug-induced or some other thing, but I had to just delay the cycle and then it settled. But most of them have settled, and my longest living patient right now on Atezolbev is around 15 months approx, and has been doing quite well. As of now, no, I have not encountered a lot of side effects with any of both of them are well tolerated according to me.
Excellent. Prahlad, what's your experience been in terms of toxicity profile and how you've been handling them?
Most of them tolerate very well. I think immuno side effects, I keep doing urine routine every 2 cycles. And hypertension is one thing I keep monitoring. The thyroid profile, these are the main things I monitor. But most of the patients tolerate the regimen very well. Proteinuria and all we see very, very rarely.
Perfect. So I think with this, pretty much everybody's takes being Atizobev in the first line and then subsequently look at the other options in the second line. Probably, if I may, what is your key endpoint in treatment of HCC? Are you always looking at prolongation of life, which is obviously a no-brainer? How important is quality of life and preservation of quality of life in these patients? Like, you're always going and look out for response rates with intense regimes, or quality of life is top priority and go on a dose limited regime? What's your priority on the whole? Vijit is around? I think Vijit's not around. Prahlad, you want to
I'll take that.
Go ahead.
Yeah, I
Yes,
think these patients already, many a times when they come, they've got significant loss of appetite, loss of taste that's already there due to the disease. Now, with lenvatinib, that is one big issue. Okay, there are few patients who have been eating little and you make them stop eating at all. So that is one thing that I've seen, very bad dysgeusia, very bad after taste. They're not comfortable at all. In that situation, immunotherapy actually is fantastic. Okay, they hardly have any of these issues, and as disease responds, they start feeling better. So I feel quality of life is something that is excellent. See, these patients may not have a really long life, so it is only rarely that we end up seeing some really good responder or long survivor. Most time 18 months is what you see, and that 18 months keeping them sick, not able to eat, having hand foot syndrome, lot of fatigue, everything is not something that we would want. So quality of life, I think, is an equally very important endpoint that probably we should think when treating HCC.
No, definitely. I would definitely concur with what you're saying. So now that you bought in that particular component, I just want to kind of hear your thoughts on. You have the stride regime, which is 4 weekly. You have one dose of Durva every 4 weeks, and you have Etizobev, which is 3 weeks. Taking the logistics, you don't want the patient to keep coming and seeing you more frequently. Is
I
that
know.
something what you would consider?
I would consider in case patient is traveling from far. Okay. There are sometimes patients who fly from Dubai and come take treatment and go because the healthcare is more expensive there. So in that patient, definitely I would probably think of using a Durva Tremly combination. But Atezolizumab, I think Nevo EP is the one thing that is a problem. After that, when it start becoming 2 weekly, you can use 4 weekly dose, but the PAP is not too easy. They end up troubling quite a lot. So compared to that, I think 3 weekly once is something that is always good. And 3 weekly once, the advantage is these patients do come 3 weekly once regularly. Sometimes these 4 weekly, they end up coming with some significant toxicity after 4 weeks and telling that from last 3 weeks, this was what is happening, and you'll end up landing in trouble.
Sir, I'll just
Totally
pitch in
agree.
here. Like Dr. Hemant
Yeah.
has said, invariably, I think most patients anyway take 4 weekly Atezolizumab because of whatever reason. They just know either travel issues or some side effect or something else, something has happened. I think most of them don't end up taking 3 weekly only, at least in my whatever I have seen. Most of them take 4 weekly. And about the Nevo EP that now it has come into existence. And we can give a 4 weekly regimen. Maybe I know BMS has we have a lot of issues with the approvals of BMS and all. I think with Tishta, I don't know, maybe the things will be slightly different.
True. No, rightly said. I totally agree with you. Prahlad, your take on 3 weekly versus 4 weekly? You want to see the patient more frequently or less frequently? What's your take on it? Prahlad, you're around? Okay, I think Prahlad is not around anymore. Prahlad, you're around?
Yeah. I think I would prefer 3 weekly. It's I think most of my patients are on Atezolizumab only. I've not tried other regimens actually.
Okay. Perfect. So I think with this, we're coming to the last 3 minutes. Next slides, please. Is there more which we have to discuss on? Can we just kind of move to the next two slides? So it's primarily real world data, and yep, VP4 we did cover. Next, please. Next. So yeah, so are you okay with taking off, say, the BEV, especially when there are toxicities in these patients? Like, have you noticed this, or have you done this where you take off the BEV and just continue Atizo, and those who've given Atizo BEV, anybody is free to take it?
Yes, sir. I've done that for one patient. From the beginning, the patient had thrombocytopenia. It was never going above 40,000. So I had to start off with Atizo, thinking that maybe it will, help with the disease and probably the patient's thrombocytopenia will recover, but it never occurred. And I continued to give only single agent Atizo until I think 6 to 7 months, and then he progressed. I couldn't continue more than that. But retrospectively thinking, I think I should have probably started off him on single agent Durva because in NCCN guidelines, if you see the other recommended regimen, single agent Durva is allowed. You can open the tremelimumab and you can give single agent Durva. So retrospectively, I think maybe I should have done that. I have done for one patient where I skipped BEV, but then the patient progressed in 6 months.
Okay, perfect. So I think even the data is clearly there. Despite skipping doses, I don't think there is going to be an impact on the overall survival. Your still endpoint is kind of pretty much preserved in terms of both the OS and the PFS, which is what the IM Brave 150 exploratory analysis did show that. So you're absolutely right in doing that. I think one last question and let's wind up. We know majority of our patients are not going to go receive second line, or probably close to 40% are not fit for subsequent lines of therapy. So would you look at dose intensification by adding something? So if adding something, what are the ways of probably intensifying your dose if you're doing that way? If not, are you happy doing second line? What are your second line options? Probably we would start off with Hemant and then Pratyusha and then Prahlad, and then we can wind up. Hemant, your thoughts on dose intensification versus preserving the patient for second line? What are your thoughts on it? Is Hemant around?
I can take
Pratyusha, you want to take this?
Yeah,
Yes,
yeah.
please.
No, sir. Though when you mean dose intensification, maybe I would try to combine TACE wherever possible to that first line,
Perfect.
but not adding another systemic therapy drug because these patients are already mostly their liver function is almost always compromised in some form of shape, or they already have a lot of deteriorated quality of life as well. Not in the form of systemic therapy, maybe in the form of localized therapy. I would like to do some dose intensification either at upfront, or maybe once the patient starts to respond, at that point of time, I may add in some localized therapy, but not in terms of another systemic therapy. Second line will generally be cabozantinib. I am not a fan of Lenva at all.
Lenvatinib at all.
Yeah, cabo is
Perfect.
my
Perfect. No, totally. The reason I just asked you was because I think anti-TIGIT is coming big way, and anti-TIGITs in the first line is a negative study. Combining atezolizumab with anti-TIGIT was negative. So that's why I just wanted to know if we still kind of going and hitting hard with triplets, because now there's also another CAR-T in the space and ADC in the space, which is just going to kind of mature anytime soon. So are we trying to kind of dose intensify or kind of improve your outcomes by adding more, or you would probably be better off doing the second line? So that was at the back of my mind. Hemant, are you around? Is somebody around? Prahlad, your thoughts? Adding anti-TIGIT versus holding on for the patient in the second line and giving
I think I
what is
agree with
available.
most of them. I think will have some or other issues, but I think what Dr. Pratusha said, I think even I would suggest the same.
Perfect. Perfect. I think if is Hemant or Vijit, anybody joined? Okay.
They
Okay.
are
If they're
already
not,
there. They are already there on the yes session में, but must be busy.
that's all right, madam. I think they've gotten an emergency phone call or something. I think that's all right. So with this, thank you so much, Dr. Pratyusha. Thank you, Hemant. Thank you, Prahlad. Thank you, Vijit, for this wonderful discussion. With this, I would
Thank you,
like
Dr.
to
Vijay.
thank the organizers for this opportunity, and I would like to return it back to the organizers. Thank you.
Thank you, Dr. Vijay.
I thank everyone for the wonderful discussion. Now I would like to welcome Dr. Mohammad Ibrahim, DNB resident, Medical Oncology, Sakra World Hospital, Bengaluru. Over to you, sir.
Hello, thank you. Thank you for this invitation. My name is Dr. Mohammad Ibrahim. I'm one of the resident doctors. And thank you, Rosh, for sponsoring this. And thank you, Vijay, sir, for giving this opportunity. My topic would be chemotherapy-induced nausea, vomiting, which is one of the most common symptoms that we see in patients who are receiving chemotherapy. So coming to what is nausea, it's basically the inclination to vomit or feeling in the throat or epigastric region, alerting the patient that vomiting is imminent. There are 3 grades: loss of appetite without alteration of eating habits, basically some things which we always feel in day-to-day lives. And the patients who receive chemotherapy are more inclined towards the grade 2 or grade 3, where there are oral intake is decreased without any significant weight loss, or there is inadequate calorific or fluid intake, so which would require hospitalization or TPN. Next, what comes is vomiting. There are 4 grades of them as well: 1 or 2 episodes over 24 hours. Grade 2, 3 to 5 episodes over 24 hours. Grade 3 is more than 6 in the 24 hours and requires hospitalization. And grade 4 is where there is life-threatening consequences, urgent interventions is needed. So coming to chemotherapy-induced nausea and vomiting, it basically is a direct consequence of chemotherapy administration and is among the most distressing side effects experienced by the cancer patients. Without prophylaxis, up to 70 to 80% of these patients experience the nausea and vomiting. And adequate antiemetic control is significantly improving their quality of life. And by adhering to this treatment and the clinical outcomes, we can control the chemotherapy-induced nausea, vomiting. If it's not controlled, it basically leads to dehydration, malnutrition, dose reductions, which can cause the patient's difficulty in treating him for the next successive cycles. frequent hospitalizations, hence delaying the whole process of his chemotherapy, which gives the cancer to become more resistant to the drug. Classifying them into 5, there are acute, delayed, anticipatory, breakthrough, and refractory. What we most commonly see is the delayed one, which peaks at 48 to 72 hours. And mostly the neurokinin receptors play a dominant role in this, mostly seen in cisplatin and carboplatin. Refractory is something which we see rarely, where patients are failure of prophylaxis or rescue in the prior cycles, and it requires different reassessment and escalation. These are the 4 drugs, how we classify them into high, moderate, low, and minimal. And these are some of the drugs which you must be all aware about. The main, the pathway which the nausea and vomiting is mostly taken here is the acute one, which is by the 5-HT3 pathway, the serotonin pathway, and then the delayed one by the neurokinin pathways. When you come to the antiemetics which we use in our day-to-day chemo patients, the most common would be the serotonin receptor antagonists, the ondansetron, granisetron, palonosetron, which block the serotonin at vagal afferents and the chemotherapy zone, chemotherapy target zone. The main primary role would be the acute reaction. Next is the neurokinin, which whether the aprepitant, fosaprepitant, netipitant, where they block the central nervous system or the periphery. And this mainly plays in the 48 to 120 hours delayed nausea and vomiting, which is induced by chemotherapy. Corticosteroids also play a major backbone, especially dexamethasone reduces the inflammation, enhances other antiemetics, both acute and delayed. And then you have the dopamine antagonists like the metclopramide, domperidone. When you taking an overview, it basically means 32% based on the study. And NCCN also tells you that around 32% of the acute CNV occurs within 24 hours of chemotherapy administration, and the 60%, which is the majority, occurs in the delayed part. How and what are the basic pathways where you can expect the patients to have increase in this nausea and vomiting? You go with the treatment, especially the radiation and the chemotherapy, and the GI and the neurologic, metabolic, and some psychological as well with anxiety. Going to the pathophysiology, what happens is basically emesis is a controlled reflex involving both peripheral and central nervous system. The triggers are located in the gut receptors, which are sensitive to mechanical distensions, toxins, and chemotherapy. These send the signals to the vagal and the splanchnic afferents. And then the central integration, where the brain processes these signals and coordinate the motor response. So multiple neurotransmitters are involved in this process, where serotonin plays the major role, but also the dopamine and the substance P. As I said, the major 2 structures involved are in the medulla oblongata. Higher cortical areas like the limbic system, hippocampus, and the cerebral cortex also contribute to the anticipatory nausea. The 2 major vomiting the 2 major ones is the chemotherapy trigger zone and the vomiting center, which is basically the central afferent pathways, where the nucleus tractus receives the vagal input from the GI, and then there is chemotherapy stimulates the enterochromaffin cells in the small intestine, and they release neurotransmitters. This goes in a cycle, and the patient keeps going until we give these blockers and block them. In the gastrointestinal, again, you give the chemotherapy, there's damage to the cells, release of serotonin, and then the receptors are stimulated, then there's the transmission, and that's basically how it happens in the GI tract. So most of the frequent and troubling side effects the patient experienced during the chemotherapy, interfering with their compliance with cancer therapies and quality of care. There are malnutrition, impairing of the health and quality of life. There is discontinuation of the anti-cancer therapy, as mentioned. Increase in mortality and morbidity and delay in discharge from the hospital is also one of the rare ones. But moving on, we have dehydration and electrolyte imbalance, which is one of the most commonest causes of chemotherapy-induced nausea and vomiting. How do we predict this? So when you come to the first cycle of the chemotherapy, we always have to give a proper regimen, And to manage that, we have to classify them on these different drugs which patient is receiving. When you come to the perceptions of the side effects of chemotherapy, when you take it on a scale, there's rarely death seen here, but most of the common one is little or no nausea, vomiting. Fatigue and mucositis is one of the most common in the table. This is one of the chart giving you the how the nausea and vomiting are related when you come to moderate and high emetic drugs. So the management, how do we manage this? The primary goal is to prevent it. And what we have to do is first figure out the chemotherapy drug with the highest emetic risk. And also prior to the chemotherapy, we must take a proper history and also other patient-specific factors, identifying the regimen, high risk, moderate risk, low risk, and minimal risk, and the drugs which is needed. So when you come to the high emetogenic risk, the 4 drugs must be mandatorily given to the patient. It should be dopamine antagonist receptors, dexamethasone, olanzapine, and the neurokinin receptor antagonist as well. Dexamethasone can be continued from day 1 to day 4, as it also plays part in the delayed chemotherapy-induced nausea and vomiting. 12 mg per day is given as oral. 12 mg is given in initially day 1, and then we reduce it to 8 mg per day for the next 3 days. And in diabetics, we prefer to reduce it to 4 mg, considering how sugars can increase the level of. The steroids can increase the level of sugar. And when you come to the moderate one, you prefer 2 drugs, the 5-HT receptor antagonist, the palonosetron 2.5 mg is mostly preferred here with dexamethasone, IV or oral. Alternative, there are ondansetron, but palonosetron is the best long-acting preferred. And considering if there is carboplatin more than 4, we prefer adding NK1 receptor antagonist as well, as it comes in the higher upper end of the moderate emetogenic risk. Olanzapine also may be considered when standard options fail. In patients who are not able to afford netipetant or other drugs, the NK ones which are a bit costlier, olanzapine may be considered in these patients. The low risk is you can consider a single agent antiemetic. It can be dexamethasone or metclopramide or fluoxetine. Antiemetics usually does not require any antiemetic as such. You can just give them the pantoprazole and Avil. Avil also helps with it. And after classifying, this is the chart where you can follow through. Throughout the course, when NK1 was used in combination with the palonosetron, the 5-HT, there was a better control in acute and delayed chemotherapy-induced nausea, vomiting. As you can see in the chart, you can see when giving the drugs together, there was a higher patient-free time, patient-free of emesis percentage, but compared to the other drugs where just the NK1 or the 5-HT were combined with dexamethasone. Principles for managing the breakthrough. So to managing breakthrough nausea and vomiting, we add an agent from different class. We schedule antiemetic therapy rather than PRN dosing. We use multiple agents like lorazepam, metclopramide, haloperidol, and alter preventive therapy for the next cycle of chemotherapy. There are some considerations in special population, especially in elderly patient. We can reduce the olanzapine due to risks like falling or sedation and extrapyramidal syndrome as well, and avoid high dose of metclopramide for the extrapyramidal syndrome. Risk of constipation with palonosetron, so monitoring bowel is important, and dose adjust renally cleared agents like granisetron. In aprepitant, it usually has a hepatic impairment, so use it with caution. Dexamethasone generally safe, just need to monitor glucose levels. Drug interactions, as aprepitant inhibited CYP3A4, monitor warfarin and dexamethasone and vincristine. Palonosetron has minimal CYP interaction, so it's more preferred. Metclopramide with QT prolonging drugs is something you have to avoid. For example, you have your basic antibiotics and even pantoprazole. Moving on, dexamethasone may be adjusted as usual.
Hello.
Yeah.
PARP inhibitor and monotherapy combination, I don't think there is a priority. So,
I'm sorry. Okay. Moving on, pregnancy and fertility. Ondansetron considered as the FDA category B. Avoid first in the first trimester if possible. Dexamethasone use lower effective doses and caution in the first trimester as well. And metoclopramide generally considered safe. And avoid cannabinoids. Cannabinoids are not usually used in the practice. However, we can have a talk on that as well. Non-pharmacological approaches include dietary modifications like small frequent meals, avoid strong smelling, spicy food, prefer cool.
Hemant, what would you do? Sorry, I was on a call. I missed the question. What exactly?
What would you do in the patient where BRC is positive? Yes, for more than 20%.
Good question. All guns? No. I'll probably start with chemotherapy and IO in first line because I still feel PARP works, but works more probably when the bulk of disease is lesser. So it works well probably when we are hoping that we can maintain this patient and becomes a good option for this. I'll start probably with chemo plus IO, see on first line. And probably after completion of chemo, try to see if I can use
can we please
PARP
mute
with IOF maintenance because in prostate
can
you
we
have data for
please
that.
mute
I'm just hoping
Dr.
that
Hemant at the back end, please?
I guess I'll continue.
Ibrahim, you can continue.
Yeah, thank you. So to monitor some things, for example, complete response, there is no emesis, no rescue, and total control, there is complete response plus no impact on daily activities. Needing to assess every 24 hours and when to escalate when there is persistent vomiting more than 24 hours despite prophylaxis, give fluids and rescue antiemetics, weight loss of more than 5% or clinical dehydration, electrolyte imbalance like hyponatremia, hypokalemia, which are very common in vomiting, and consider adding neurokinin 1 receptor antagonist if not already prescribed. Some assessment tool which can also help in the day-to-day life of especially in when it's coming to all the drugs which are more than hundreds to remember. Documentation is one of the most important and most primitive way of keeping track of everything. Record the number of emetic episodes and nausea and vomiting related occurrences. Rescue medications to use between cycles and review and optimize the plan for each cycle. And also, we all have clinical pharmacologists in our hospitals, so it's better to involve them as it's more also one of their area, one of their strong points, which can help us in our daily administration process. Key takeaways is prevention of nausea and vomiting is essential. The high emetic drugs require 4 combinations. Always cover the delayed phase, that is 24 to 120 hours. Pionosetron is more preferred due to its delayed phase efficacy and long half-life. Reassess and optimize antiemetic prophylaxis every cycle. Non-pharmacological strategies and patient education are integral part. They play more than 50% of the role. Risk stratify every patient and involve pharmacists. And antiemetic regimen should compromise of agents with different mechanism of action as it covers all the areas, the gastro, the peripheral and the afferent and the central nervous as well. This is a small summary that you can have it in your daycare just to make sure you're not missing anything and to cross-check as well. Thank you.
Thank you, Dr. Abraham, for the talk.
Yeah.
Now I would like to again welcome Dr. Vijay Kumar, sir, for the next session. This session is sponsored by DRL, Dr. Reddy.
Thank you. Good evening. Can I have my slides, please? Good evening to one and all. So, firstly, I would like to thank Dr. Reddy's for giving me this opportunity to talk about this particular very important topic. Next slide, please. Which is going to look at the impact of supportive care primarily when to avoid blood transfusion. So, enhancing immunotherapy outcomes, why avoiding non-essential blood transfusion matters. Very interesting slide set and a very, very important topic. Next slide, please. So this is my scheme of presentation. It's going to be a little bit on the background, then chemotherapy-induced anemia, then what is transfusion-related immunomodulation. Then there is some studies as well as real-world data and some studies from India as well. Next slide, please. So when we look at the current landscape, what's happening is we clearly know that there is rapid expansion of IO. We did have a couple of talks on the same. And you've also seen a lot of these adoptions just as the typical oncological hierarchical way of oncological evolution. Drugs from the palliative or rather from the palliative regimes move into the adjuvant regimes and then neoadjuvant regimes. And this is what's been happening. And the same is being seen across immunotherapy as well. And supportive care is also becoming equally important because it's important to maintain the dose intensity, not to miss out on the regimes, no treatment delays, and make sure that the patient is immune fit. Thereby, the outcomes are not compromised by just giving supportive care. Next slide, please. So when we look at this, why is it important? Because it's going to have a lot more impact on the overall outcome. And blood transfusions, when to give, when not to give, what is appropriate. Can we use chemotherapy? I mean, can we use erythropoietin stimulating agents like darbepoetin alpha? Can we use it in metastatic? When in a curative setting can we do it? These are things what we're going to discuss a little bit in detail. Next slide, please. Next slide, please. So when we look at what cancer-related anemia or CRA is, we know it's primarily you have this a different entity which is secondary to CKD or patient with CKD having anemia. But what is of importance is one is the chemotherapy induced, which is primarily because of myelosuppressive effect on the marrow. And the secondary, or it could be secondary to a particular cancer, like say there could be a defect in production, there could be destruction, or there could be blood loss. Next slide, please. So it's important to understand what the etiology is. So etiologically, next slide, please. So when you look at the etiological classification of anemia, it could either be myelosuppressive, causing bone marrow failure and anemia, or it could be because of, say, the disease per se, where there is low secretions of interleukins, there's hepcidin overproduction in the liver, causing lower erythropoietin and impaired erythropoiesis. So all of these does contribute to anemia. So it's a compounding cycle, which is basically a mix between the two. Majority of the times, especially while patients are on chemotherapy, these components also tend to aggravate. So it's a very it's a difficult decision to make, especially when they're on chemo. But when they do not have chemotherapy, it's easier to evaluate. So it's very important to evaluate a patient for anemia, or especially when you have anemia, important to evaluate for the cause at the baseline to kind of prevent your toxicities while on chemo. Next slide, please. So when you look at this is the same pictorial description of what exactly happens, the pathogenesis, the nexus of inflammation with hepcidin overproduction, the hypoxia, what happens, all of these lead to significant decrease in the hypoxia ischemic factor, thereby leading to decreased erythropoiesis, leading to erythropoiesis failure, and then you have cancer-related anemia. So there's a combination of both of these because it's fundamentally driven by immune-mediated functional iron deficiency, but whereas the endogenous erythropoietin production is also significantly reduced or suppressed. Next slide, please. So this is what happens because with time, there is a significant symptomatic burden. These will cause significant chemo delays and dose reduction. Ultimately, we've seen this in practice that once you've gone in for dose reduction, dose delays, this will definitely result in a shorter lifespan as well as increased disease progression. So this is something which is very important for us to note. So treatment compromises are important and we will have to try and address the symptomatic burden upfront. Next slide, please. So how do we define? So this is, I think, let's skip this slide. Let's not look at all of these. And we know what the definitions of anemia is and what are the additional investigations which are needed. So always along with the routine CBC, get in retic count, and if there is a anemia or a baseline, grade 2 and above anemia at baseline, it's important to evaluate for these, especially for if there's a stool for occult blood, get in your iron, get in your TSATs, get in your TIBC levels. Also rule out B12 and folate deficiency, which is usually coexisting in majority of our Indian patients. Next slide, please. So next slide, please. I think this is a big burden. Nearly half of our patients do have anemia at the time of diagnosis. So it's important for us to understand that RBC transfusions over a period of time around immunochemotherapy does cause lower responses. So if we can avoid transfusions, we plan to avoid, especially if there is correctable causes or modifiable causes for anemia. Please try and modify that, especially if it's nutritional or say a metabolic cause or something else which is predominantly the reason why it is. Try and eliminate these, thereby your patients have a better performance status by the time they start chemo. Next slide, please. Next slide, please. So when we look at overall, how do we look at it? So this is a very important slide on differentiating absolute versus functional iron deficiency. Always look at your TSAT scores and your ferritin. If your ferritin is extremely low, under 100, and your TSAT is say under 20%, there is absolute iron deficiency, and patients have to be corrected with IV, which is mandatory. But otherwise, if they fit into the mid where your TSATs are between 20 and 50 and iron somewhere ranging between 100 to 800, this is the place where you can go in with erythropoietin stimulating agent plus minus transfusions. But when your TSAT is above 50%, iron supplementation is actually not indicated. So this is something which is very important for us to note, looking at ferritin and TSATs while we make decisions on, which is very important for us in our routine day-to-day practice. Next slide, please. Next slide, please. So this is exactly the same workup what we looked at. And when we look at, once we've looked at it, why is it important? So again, we always have to remember transfusion of blood is not just delivery of oxygen alone. It also it's basically giving in another immune active biological product, because there is allogenic transfusions do have a lot of other, although it's leukodepleted and we do consider leukodepleted transfusion in certain situations, it does have a lot of other cytokines, a lot of other HLA factors and all of these, which is responsible for the immune cell reprogramming and T cell expansion and suppression. So this is all of it eventually will cause the immune tumor microenvironment to cause a very immunosuppressive environment, and that can lead to a lot of immunomodulation, which is why transfusions have to be very, very cautious and should not be considered, should not be routinely done until otherwise warranted. So this was a study which is looked at, which was published in Frontiers, where they looked at it giving in patients who've received blood transfusion 30 days prior and 60 days after immunotherapy, their outcomes have reduced significantly. Next slide, please. There's around 31% reduction in the overall survival, or rather the response rates. Treatment response rate is 31% reduction in the response rates, especially for patients who've received transfusion either 30 days prior or 60 days after immunotherapy. So that's something, although this is a retrospective study, it's very important for us to understand that these components could actually be the reason why patients are not responding. Next slide, please. And when you look at this was also another retrospective study which said that there is around 3.9 months shorter PFS versus 8.2 months in patients who have received transfusion. So there is reduction in the progression-free survival as well as overall survival. This was in a study in lung cancer patients where they received PRBC transfusions within 120 days from the time of checkpoint inhibitor. So clearly saying that transfusion is not something which we should routinely consider until and unless it is really warranted. So that will compromise our PFS and OS. Next slide, please. And when we look at the dapipoietin, which is what is an erythropoietin, which is an alternative for blood transfusion, which can be considered in majority of your settings. So the concern with EPOs have always been that there is increased risk of thromboembolism in the metastatic setting. That's something you don't want to be doing. There is also a lot of data saying that it can aggravate your tumor or increase your risk of progression and kind of contribute to increased mortality. So to kind of put all of this to noise, there was a study. So there was this mandate which said that you have to prove strict non-inferiority in survival before claiming any efficacy in anemia management. This was for dapipoietin alpha. Next slide, please. So this was a study which randomized. It was a randomized study in advanced NSCLC. What they looked at was primarily dapipoietin versus placebo every 3 weekly in patients who receive more than 2 additional cycles of first-line immunosuppressive treatment. To show that there is a non-inferiority, and the non-inferiority upper margin was to be under 1.15. Next slide, please. So this study did show that the non-inferiority margin was, the hazard ratios was 0.95, and the upper limit of confidence intervals 1.04, which was well lower than the predefined non-inferiority margin of 1.15. So clearly saying that there is no difference in kind of giving darbepoetin, and there is no increase in toxicities. Next slide, please. I think there's also clear mention that there is no increase in the thromboembolic events, although a marginal 2.8 versus 2.3, but the incidences of serious adverse events were very similar. There was also no aplasia, which was secondary to the erythropoietin stimulating agent. So this says that is pretty much low, and EPOs can be considered and does not really have a significant, does not really contribute to increased toxicity. Next slide, please. And these are the mechanism of actions. Let's not deep dive into it. So clearly EPOs, something where the risk of transfusion, the VP profile is very low. When you look at blood transfusions, there is slightly higher risk, and also risk of TRALI, aluminization, sepsis is also something what we've all kind of come across at one or the other time point. The only drawback here is this takes time. So when you kind of see a trend in hemoglobin dropping, because you need a bare minimum of 4 to 6 weeks of treatment for kind of creating this bone marrow stimulation for the erythropoietin, for your hemoglobin to go up. So early intervention is key, and risk of toxicities are comparatively very low when you use EPO. Next slide, please. So when we look at what the patient profile is, so it's important to understand when do you give it, how frequently do we give it, what is the patient profile. So early initiation is key, and you thereby, if you initiate early, you can kind of reduce the risk of transfusions, and accordingly you can use it safely. There is no risk of thromboembolisms. Next slide, please. So this is, I think, the Indian data. There are two studies, which is, next slide, please. So this is again a real world data from India, where they looked at all of these patients who have received chemo-induced role of erythropoietin stimulants in the management of CIA. So where they received 500 mg darbepoetin every 3 weeks. So this was the patient distribution. Next slide, please. So this study also did show that there is improvement in the median survival. So there is, especially the decrease in, or there is a significant improvement in the hemoglobin. From the baseline, there was an improvement of around 2.3 grams per deciliter, which is very significant. And the failure rate was very, very low. So only 10 out of 233 patients actually failed. So all of them were having very good improvement. So they defined failure as basically primarily needing PRBC transfusions ultimately. So only 8 patients ultimately required RBC transfusion. So early intervention with darbepoetin stimulants are actually going to be very significant, and this will help us over a long run. Next slide, please. So there was also another study from India. Next slide, please. There's another study from India which has also looked at it. So another 523 patients from India predominantly. Next slide, please. So they did look at the way this the benefit on the whole, and it's the same. There is a good 2 gram per deciliter improvement from the baseline, which is very, very significant. Next slide, please. And a 56% reduction in blood transfusion dependency from the highest risk cohort. So clearly says that erythropoietin stimulating agents are here to stay, and early interventions key, and you do improve the patient's hemoglobin with time, and also reduce your risk of blood transfusions, thereby not kind of not causing some kind of a resistance to immunotherapeutic outcomes. Next slide, please. So when you look at the real world data as well, it's pretty much very similar, although there is a class effect which is of that is DVT. The percentages what you see in real world is actually extremely low, which is around 2.9%. Cardiac toxicities of around 1% cumulatively is also seen in these patients when they receive. Next slide, please. So with this, we know that there is robust biochemical efficacy, there's critical resource optimization, and restored patient's anatomy, patient's autonomy by using these things. Next slide, please. So putting these things into perspective, this is where the ESMO and NCCN guidelines have come in. So in curative intent, still they say erythropoietin stimulating agents, the kind of evidence is still insufficient. But in palliative care, especially metastatic setting, it's very, very clear. Initiate when it's less than 10 grams. ESA is definitely level 1. If it's less than 8 asymptomatic, then initiate ESA. Only in symptomatic patients, especially when the hemoglobin is under 7 or 8. So again, 7 or 8 only under 7 is where we start considering transfusion. 7 is the cutoff what we routinely use. It's important to maintain a stable hemoglobin of anywhere about 10. 12 is ideal, definitely. Next slide, please. So I think across guidelines is pretty much the same. If you look at even say clinical guidelines across, it's important to initiate PRBC transfusions in patients if they are symptomatic under 10, asymptomatic initiate at up to under 8. This is where you want to consider. Next slide, please. So with this guideline recommendations, which is what it is across usage, which is what we reiterated to, important to consider erythropoietin stimulating agents and maintain hemoglobin somewhere between 10 and 12. So with this, I would conclude. And next slide, please. Yeah, so the major gap analysis and local needs, if you look at it, the primary aim is to comfort with current approach, get in your diagnostics right, cutoff, ferritin cutoff value is very important. Safety profiles, if you look at it across ESAs or VTE concerns, in the non-curative, lowest effective doses is definitely something which can be used. And local patient profiles, it's important to define iron deficiency. If there is baseline deficiency, say severe anemia at presentation, try and correct it. And you have these pathways which can be used more frequently, either 2 weekly or 3 weekly, to reduce the visits. Thereby, the patient's outcomes are better by when their hemoglobin is improved. Could you move my next?
So you want us to
Am I audible?
Yes, sir.
Perfect. All right. Thank you. Back to the organization.
Thank you, sir. Now I would like to welcome Dr. Vishwajit Pai, sir. He is consultant medical oncologist, Aster Hospital, Bengaluru. Over to you, sir. This session is sponsored by Roche.
Good evening, everyone.
Good evening, sir.
I think the previous person should stop sharing so that I can share. Are my slides visible now?
Yes, sir. It's visible.
So good evening, everyone. This is a presentation on the real-world evidence of the use of Tecentriq bevacizumab in advanced hepatocellular carcinoma. We did have a session earlier on the use of Tecentriq and bevacizumab. So that was discussion based on the clinical trial. This is real-world evidence. So this presentation is sponsored by Roche. So we are all aware of the three trials that brought in IO agents in the treatment of first-line metastatic or unresectable hepatocellular carcinoma. We had the IM Brave 150, which utilized Tecentriq with bevacizumab. Second one was the Himalaya, wherein durvalumab and tremelimumab were used, and the third one is the Checkmate trial where nivolumab, ipilimumab was done. So this we've had a discussion earlier on. So if you can see that the highest, the best HR hazard ratios were seen with Tecentriq Bev combinations, and we'll just go through how to find out how well are we able to replicate the same in clinical practice. So based on this study itself is which made the IO VEGF combination as the standard of care. So what is the importance of real world data? RCT is used in tightly controlled populations, and it needs regulatory approval, whereas real world data, it is on day-to-day practice. Patients are selected from day-to-day clinician practice. They give exactly the mirror image of how exactly are the data from clinical trial that come into the practice. It could be superior, it could be inferior. Many times the real world and RCT, the arms, the exactly the directions, they don't match. So RCTs are trusted mechanisms for evidence generation. They help in clearing hypotheses. It is often a very strictly selected patient population, which is often very hard to find on a day-to-day practice, and the protocols are quite fixed, and they're not flexible. The results from a clinical trial form the basis for treatment guidelines, whereas real world data are the regular day-to-day practice that we do. It supports a wide variety of clinical decisions. It supports regulatory approval. The various complexity is eliminated, and there is need for extrapolation. So there is this real world data that we are going to discuss today. So since IMBrave 150 got published in January 2020, there are 123 real world publications, 7 meta-analysis, and more than 100 case studies. So these are some of the most prominent ones: Castro et al., AB Real World, Rimini et al., and Ramaswamy et al. So we will discuss one particular study that is called the Chief Hepatolong study. So this is a extended follow-up of atezolizumab, bevacizumab in patients with advanced hepatocellular carcinoma. This is a multicentric study from France, and the aims of the study was to evaluate overall survival, progression-free survival, and the best response. So as I said, it's a multicentric study done from 2020 to 2025. All patients who received atezolizumab, bevacizumab in the first line were included, and patients, the primary exclusion criteria was Child-Pugh score C and BCLC D. Overall survival and progression-free survival were assessed using Kaplan-Meier curve. Objective response were calculated. So this is what we are looking at. Since 2025, the number of patients that were treated in the first line were about 900 patients, of which excluded were about 14 patients. So data for analysis, about 880 patients have been taken. Average age is about 69 years, predominantly male population. Here we have a mixture of alcoholic, viral disease, non-alcoholic fatty liver disease, etc. Most patients were Child-Pugh A. They also considered MELD as well as ALBI score. ALBI score is albumin bilirubin index. Major areas of concerns were the presence of esophageal varices and ascites. They have also considered the BCLC class A, B, and C during stratification. So if you look at the overall survival, since this is single arm, the overall survival at 42 months was 44%, and the predictive factors for mortality, some of the 3 major predictors of mortality were presence of esophageal varices, presence of ascites suggesting that the disease is quite advanced, and the ALBI score of grade 2 or more. So this is based on the Child-Pugh score. Patients with Child-Pugh A definitely did better than patients in Child-Pugh B, the difference was quite significant, 27 months versus almost 10 months. And with regards to BCLC class as well, BCLC B did better with a median OS of 28 months versus 18.5 months. Based on the ALBI grade 1 patients definitely did better as compared to grade 2. Presence of vascular invasion again makes the prognosis worse. The median progression-free survival in the IM Brave study was about 6 months. Here, the median PFS was about 5.8 months, mirroring the clinical trial. So the predictive factors for progressions were presence of Child-Pugh B, NLR of more than 2.7, BCLC class C, and AFP of 1. The PFS based on Child-Pugh A, as expected, Child-Pugh A patients will do better 6 months versus 4.6 months. As per BCLC, B did better than C. And the best, this is an important one. What was the response that was seen? Objective response was seen in about 28%. That is either complete or partial response. Stable disease was predominant in about 50%. Progressive disease in first line was seen in about 22%. So these are the results. 44% of the patients were surviving until 3.5 years, which is unprecedented. The median overall survival of 23 months after having analyzed 880 patients in the study. So I conclude by saying that overall survival rates at 42 months were indeed path-breaking with the utilization of atezolizumab, bevacizumab, and it continues to remain the favored regimen in patients with advanced hepatocellular carcinoma. Thank you. That will be my concluding slide.
Thank you so much, Mr. Sir. Now, I'd like to invite Dr. Ashwini, consultant dermatologist, Site Care Hospital, Bangalore. Ma'am, over to you. Am I audible?
Yes, Daud, you are audible.
Ashwini, ma'am. Pooja, ma'am, please call Dr. Ashwini, ma'am.
Yeah, Dr. Ashwini is there.
Am I audible?
Yes, ma'am.
Yes, ma'am.
Hi. So can you just press?
Ma'am, you
Share
have
screen?
joined from 2 devices.
Have I joined? Like, can you start?
Ma'am, your voice is echoing because you have joined from 2 devices. So I request you to log out from 1 device.
Is it better now?
Yes, ma'am. So the screen is visible to you, ma'am?
Yeah, the screen is visible.
Okay, go ahead. Thank you.
Okay, hi everybody, I'm Dr. Ashwini. So cutaneous manifestations, there can be direct or indirect involvement of the skin in various visceral malignancies. Direct means that there is presence of tumor cells in the skin. So cutaneous metastasis can occur from cancers of the lung, large intestine, and kidneys. That is most commonly seen in men. Next slide, please. And when it comes to women, we see that it's associated mostly with breast and large intestine. In case of indirect involvement, there could be absence of neoplastic cells, and that is where it is called as paraneoplastic syndrome. And this indirect involvement could be because of various factors that could be inflammatory, proliferative, metabolic factors. These are caused because of polypeptides, hormones, cytokines, growth factors, which act as mediators, and that interferes with cell communication and consequently with its activity. So Kurth proposed a criteria for diagnosing paraneoplastic dermatosis. Next slide, please. So the criteria includes that, say, the cutaneous manifestation, that is the skin manifestation, whatever we are seeing, that and the internal malignancy, they could be diagnosed either simultaneously or within a short interval. Sometimes both of them can run a parallel course, or sometimes it could so happen that, when we're seeing the skin changes, they could clear once the malignancy is cleared, or they could relapse if the malignancy recurs. Certain specific type of neoplasms can occur, paraneoplastic conditions can occur in certain general, is not very common in general population. And there is always a statistically significant association seen between cutaneous manifestation and internal malignancy. Sometimes there could be also genetic association which could exist between the internal malignancy and specific cutaneous disease. Next slide, please. So cutaneous manifestations of internal malignancies, they are grouped into 4 categories. Like I said, one, it could be because of proliferative or inflammatory. Second, it could be some amount of genodermatosis associated with these internal malignancies. Third, it could be inherited immunodeficiency syndromes. Fourth, it could be because of a hormone secreting tumor. Next slide, please. So when it comes to proliferative and inflammatory dermatosis, the first one that we see is, next slide, please. Acanthosis. Acanthosis is basically like a dark, velvety, the appearance over the neck or any flexure. And this is usually seen with adenocarcinoma of the stomach. It could be seen as tripe palms, that is where there is hyperkeratosis. That means there is increased thickening in a wrinkled or ridged pattern, which is seen on the palms. And this is associated with squamous cell carcinoma of the lung. Next slide, please. There is a sign called as lesser trellat. Here we see basically it is going to be like small skin tags kind of a thing, which is seen all over. That is, there is sudden increase or there is rapid increase in size, and it is multiple. And this usually when we see that, okay, there is a lot of seborrheic keratosis which is occurring on the back, it is always associated. I mean, it always cautions us to just check for internal malignancies. One of the most common malignancy that we see in association with this lesser trellat sign, that is increased seborrheic keratosis, is carcinoma of gastrointestinal tract. Next slide, please. There could also be Bézek syndrome, where there is acrokeratosis paraneoplastica. Acrokeratosis means all the like areas like nose, ears, distal extremities. All these things, there is a psoriasiform or a erythematous plaque which is seen in nose, ears, and distal extremities, and this is usually seen in cases of carcinoma of upper respiratory tract, or it could also be seen with digestive tract. Next slide, please. This is again where you see the extremities involved. You see the ears, you see the toes. Next slide, please. Next one is called as palmoplantar keratodoma. Palmoplantar, as the name suggests, there is increased thickening which is seen in the hands and feet, and this could be associated with esophageal carcinoma, adenocarcinoma of gut, lung cancer, basal and squamous cell carcinoma. Next slide, please. Sometimes people present with generalized itching. Like there are so many cases where if the generalized itching which is not just controlled with the regular antihistamines, we always do a workup and see if there is some internal malignancies, and we have also detected lot of lymphoproliferative disorders in people who have come to us with generalized itching. So generalized xerosis and generalized pruritus is I feel the most common skin manifestation that we see with any of these malignancies. It could also the other skin manifestations include pityriasis rotunda. Rotunda means round. Pityriasis means scaling. So basically, you're seeing some scaly round lesions which are on the trunk, and this could be associated with hepatocellular carcinoma. There could also be exfoliative dermatitis. Exfoliative dermatitis is nothing but generalized erythema. Generalized erythema means generalized, there is full complete body is filled with redness and scaling. So that is more than 90% involvement of the body. I mean, if you see that the person is having some amount of itching, there is redness, and there is a lot of scaling, then we always suspect it. There could be cutaneous T cell carcinoma, or it could also be lymphoreticular malignancies. Next slide, please. We also see this acquired hypertrichosis lanuginosa. Lanuginosa means you can see that this hair, which we usually see in case of babies, you see this fine hair. It is mainly seen on the nose, on the face, on the neck, trunk, and extremities. This, along with some changes on the tongue, that is, it could be glossitis, there could be cheilitis, there could be swollen red.
Ma'am, your voice is not coming. Dr. Ashwini, ma'am?
Hello, can you hear me?
Now we can hear you.
Okay. So, I'm sorry, did you hear the slide, or shall I go again?
Ma'am, please over it again.
Okay, fine. So, dermatomyositis is a condition where there is skin changes, also with myositis. Myositis, that there is proximal myopathy. So, the skin changes include classical heliotrope rash. So, there is a purplish red rash which occurs on the face. I'm not able to see the slide. I'm not able to see the slide. Sorry.
Yeah, ma'am, 1 minute. Daud, can we just Pooja ma'am, can you show the slide?
मैं शेयर करती
Yeah, please share.
Can you see my screen?
I
Yeah.
can see your screen. Can we go to the dermatomyositis slide, please?
Next. Go to next. Yes. Yes, this one only. This
Yeah.
one only, right?
So this one only. So in this picture, you can make out that there is a purplish red rash which is near the on the face, which is actually around the eyes. Then you can see some on the knuckles, some small papules, and you can see that she's not able to climb the stairs. So there is some amount of proximal myopathy as well. in case of dermatomyositis. So there is both skin changes, muscle changes, as well as there are some internal malignancies which are associated with this particular disease. Next slide, please. Next slide, please. There's also multicentric reticulohistiocytosis, where we can see infiltrated violaceous papules and nodular lesions, and Sweet syndrome. So this is associated with pancreatic adenocarcinoma, squamous cell carcinoma of the lung, as well as metastatic melanoma. Next slide, please. So neutrophilic dermatosis or sweet syndrome. So sweet syndrome is not really that sweet. It has a lot of erythematous. That means there is a reddish, painful. The important thing about sweet syndrome is it's tender. Tender papules, plaques on the nodule or nodules on the face, extremities, upper trunk, sometimes with vesiculation. That means there can be some amount of vesicles or pus on the surface. And this is commonly seen in AML cases. Next slide, please. So pyoderma gangrenosum is basically a non-healing wound. If there is a wound which is not healing for a long time, then again we suspect that there could be an underlying malignancy. So the underlying malignancy could be one hematological malignancy, there could be a monoclonal gammopathy, there could be non-Hodgkin's lymphoma or a myeloma. So any non-healing wound with large spreading purulent ulcer with cyanotic overhanging border. So this is one of the most common cutaneous manifestation that we see in a regular OPD base. I mean, like regular basis as a dermatologist. I've seen pyoderma gangrenosum. I've seen like generalized pruritus. All these are like common things where we have found out okay that they have some internal malignancy just because they had a cutaneous manifestation. Next slide, please. So when it comes to vasculitis, in case of myeloproliferative disorders, they could have repeated palpable purpura. It could just be a skin condition, but sometimes it could have an underlying myeloproliferative disorder. Next slide, please. So this condition called as erythema gyratum repens, where there is, you can see here that there is wavy urticarial bands, that is there is some red color bands that you are seeing with fine scales, and it is migratory. So this keeps moving from one place to another, and this is usually seen with lung, esophageal, breast cancers. Next slide, please. So certain hematological malignancies could have extensive areas of purpura, so which may be figurate, it could be linear, it could just be a line, or it could be diffuse. It could be non-palpable, maybe associated with DIC. So and it could be associated with Trousseau syndrome, that is migratory superficial thrombophlebitis with multiple DVTs. So this is something that we usually see with hematological malignancy, or it could also be seen with tumors arising from the pancreas, lung, prostate, and hematopoietic system. Next slide, please. Sometimes paraneoplastic pemphigus, so that is basically if we are seeing a lot of bullae, that also could say that there is an associated malignancy. It could be Kettleman tumor, NHL, thymoma, follicular dendritic cell sarcoma, and CLL. All these could be associated in case, so many times when we are seeing somebody over the age of 60, they are developing a lot of bullae which are sudden onset. Again, we could suspect that there could be an internal malignancy. Next slide, please. In case of hemochromatosis, metastatic melanoma, there could be diffuse hyperpigmentation. In Cronkite-Kanada syndrome, there could be diffuse cutaneous and mucosal hyperpigmentation. And in case of melanoma, there could be vitellogenous depigmentation as well. In case of, they could be associated with liver carcinoma and melanomas. Next slide, please. So amyloidosis, we see changes like waxy papules, nodules, purpura, macroglossia, and this could be associated with myeloma. Next slide, please. So scleromyxedematis changes we see associated with myelomas. Next slide, please. So extramammary vegetates is basically erythematous plaques, which is other than breast. So this could be seen in case of adenocarcinoma of the rectum or anal canal. Next slide, please. Clubbing could be a manifestation of lung cancer, metastatic tumor of the lung, or pituitary tumor in case of acromegaly. Next slide, please. Nails could be distorted in case of mycosis fungoides or laryngeal carcinoma. There could be yellowish color of the nails. Sometimes there could be even loss of the cuticle, and there could be erythema and edema of the proximal nail folds. Next slide, please. Certain genodermatosis could have cutaneous and internal malignancies. Next slide, please. Cowden syndrome. Next slide. Britoge. These are all genodermatosis which could have an associated underlying. There could be a renal carcinoma in case of Britoge-Dub. Next slide, please. Muir-Thor can be seen in where there is a lot of extensive keratoacanthomas, which is seen in colorectal carcinoma. Next slide, please. There could be a lot of epidermoid cysts seen in case of colorectal, thyroid, duodenal carcinoma. Next slide, please. Both the NFs could have neurofibromas associated with, sometimes there could be a malignant transformation. Next slide, please. Tuberous sclerosis could also be associated with some cancers like renal cancer and CNS tumor. Next slide, please. This is tuberous sclerosis, where you can see the adenoma sebaceum, Sjagren patch, ungual fibromas. They could be associated with some malignancies. Next slide, please. So xeroderma pigmentosum, this is very commonly associated with leukemia. I mean, those people are associated with leukemia, cancers of the breast, lung, pancreas, stomach, testis. All these carcinomas can be seen in them. Next slide, please. Next slide. Next slide. So Bloom syndrome also could have associated malignancies like leukemia, lymphoma, adenocarcinoma of GIT. Next slide, please. Rothman-Thompson syndrome. This also is associated with osteosarcoma, fibrosarcoma, gastric carcinoma. Next slide, please. Ataxia telangiectasia means there is some amount of ataxia plus telangiectasia, which is seen on the bulbar conjunctiva, cheeks, corners of eyes, ears. This is seen associated with leukemia, lymphoma. Next slide. Sometimes it could be tumors which are hormone secreting along with some cutaneous manifestation. So glucagonoma syndrome has necrolytic migratory erythema. Next slide. Next slide, please. So in this picture, we can make out that there is some amount of erythematous rash, which can be geographic. That means geographic succinate, and it can keep moving from one place to another. That's why it's necrolytic migratory. That means it could move from one place to another. It is erythematous. That means it is reddish, and this could be seen in the groin area and even in the face area. Next slide, please. So these are all the areas associated: perineum, abdomen, groin, buttocks. Next slide. Next slide. Next slide. So carcinoid syndrome is where there is flushing, cyanotic flush, telangiectasia resembling rosacea. This could be seen in tumors of appendix and small intestine. Next slide, please. Next slide. So MEN syndrome is also associated with carcinoid-like syndrome in case of men, and these are associated with medullary thyroid carcinomas. Next slide. Next slide. So ectopic ACTH, there can be intense hyperpigmentation, and it could be associated with small cell carcinoma of the lung, carcinoid tumors, and pancreatic islet cell tumor. Next slide. Next slide. Next slide. So in breast carcinoma, we see changes like nodular carcinoma erythropoiesis, carcinoma incursus, telangiectasia, zoster-reform, and alopecia neoplastica. These are all the changes that we commonly see in case of breast cancer.
Ma'am, sorry for the interruption. Kindly conclude.
Okay, thank you for the opportunity. These are the small skin changes that we see in case of breast carcinoma, and this is, I think this is my last slide. So this is Sister Mary Joseph nodule, where you see a subcutaneous nodule in the umbilicus caused because of the metastasis from an intra-abdominal malignancy, which is seen in case of gastric adenocarcinoma and cancer of the colon, pancreas, and ovary. Thank you.
Thank you, Dr. Ashwini. Thank you, ma'am. Now I would like to again welcome Dr. Vijay Kumar for the closing remarks.
Well, thank you. Thank you so much. At the outset, I'd like to thank Horizon for giving me this opportunity and also for this wonderful organization. And I'd like to thank all the panelists and the speakers for making this a successful event. Thank you so much. And let's be back soon with more updates in other different subsites. And again, I would like to thank my sponsors, all the three sponsors, Roche, Glenmark, as well as Dr. Reddy's. Thank you and good evening. Have a good weekend. Bye-bye.
Thank you. Thank you, sir. Thank you, everyone, for joining. And thanks for the wonderful session. Thanks to our academic partners. And thanks to my colleague Pooja and Daud for supporting. Thanks to the technical team. Thank you, everyone, for joining. And good night, everyone.